those of you who always wondered about randomization in clinical trials, this is the randomization rap. Got those winter coughs and sneezes, those influenza-type diseases with this pounding head and chills and shakes and nighttime sweats with muscle aches. Got blood pressure high or low? Got a problem with your urine flow? Got ears clogged up with too much wax or skin with red unsightly plaques? Got arthritis, mastitis, gastritis, colitis, pink eye from conjunctivitis, malaria or Zika virus from insects that creep up and bite us. No matter what, with no hesitation, get to the doctor for some medication. Show insurance card and confirm address, and fill that prescription at the CVS. But will that drug be efficacious? Don't mean to sound ungracious, audacious, pugnacious, but is the evidence fallacious? No benefit you can detect, approved on just placebo effect. Oh, tell me, how can I be sure this really will affect a cure? For doctor, I am deathly ill. Don't be giving me no sugar pill. So every novel medication needs a new drug application, an NDA, so the EMA can truly say this keeps some disease at bay. It treats depression, shrinks a tumour on more than just an old wife's rumour, cures hemorrhoids or impotence with high statistical significance, or clears up plaque psoriasis by disproving the null hypothesis, or keeps some stroke survivor alive with a p-value of 0.05. You've got the common characteristics, all of this proven with statistics, a reliance on science, and clinical trials with regulatory compliance. So the standard scientific credo is to compare the drug against placebo to see if there's a difference in drug response or adverse events. And if the trial is well designed, the drug gets randomly assigned. So you will find those on dummy don't know or mind. It's only kind to do the treatment double blind. But for bias to be nullified, the patients must be stratified by age or sex or disease condition or some genetic predisposition or other data coming from the physician to make the appropriate cohort decision. And to implement this methodology, you need that interactive response technology. You need that IRT with your EDC to do the screening, check inclusion, calculate the dose infusion, immediate response, cuts out confusion. But don't give me no dated IVRS. Oh, bit 1 for no and 2 for yes. How many questions who can guess? I must confess, I barely know which key to press. Give me a web page, nothing less than send it all, HTTPS. Yeah, the only way to randomize is with web-based RESTful APIs. APIs only emphasize so you realize it's how loosely coupled systems synchronize. So next time you're in some casino rolling craps with a guy named Gambino, just take your chips and place a bet on red or black of the buck roulette. For though you might not be a hero if it comes up 00, what you're doing without realizing is watching the croupier randomizing. And we have software that does it all. It spins the wheel and rolls the ball and picks a treatment red or black with balance never out of whack. Pocock and Simon or permuted block those algorithms as solid as a rock. Now if it's hard to follow at this fast-paced rhyme, let's do it slowly. One more time. They got a drug for investigation. They make a sugar pill simulation, find some patients for experimentation. They split them up, that's stratification, assign the treatments through randomization, but keep the balance, that's minimization, and blind them all, that's anonymization. They track each drug kit transportation, every patient dispensation, count what's left, that's reconciliation. They break the blind for examination of drug to benefit correlation and safety profile indication. And if they get a confirmation of drug placebo differentiation by at least 1 standard deviation, Then you file a new drug application with 12-point fonts and pagination, wait for a years-long contemplation, the panel's final recommendation, and then receive their registration so you can get your medication. And I hope you followed this lightning recap because that's the randomization rap.